My name is Mark Pegram. I'm the director of the Breast Oncology Program at the Stanford Comprehensive Cancer Institute in Palo Alto, California. And today I'll be discussing therapeutic potential of PI3 kinase inhibitors in combination with endocrine therapy in patients with metastatic breast cancer. These are my conflict of interest disclosures. Treatment of breast cancer in the metastatic setting is complex and requires consideration of a number of clinical parameters, including the goals of treatment. Obviously, the goal is to prolong survival when possible, alleviate or prevent cancer-related symptoms, and hopefully result in improved quality of life. There are, at times, personalized medicine opportunities based on molecular or genetic tumor profiling. It's an important consideration in the modern era. Patients' treatment history and the setting of previous therapies may yield some insight as to the likelihood of resistance to particular agents that should be avoided. And the current clinical performance status and comorbidities are also important considerations, as are cancer-related symptoms. The therapeutic index is the therapeutic ideal, which is defined as the efficacy divided by the toxicity. So the safety signals from various therapeutic approaches are paramount in considering treatment options for metastatic breast cancer patients, as are patient preferences indeed. Now, this is the PI3 kinase AKT-mTOR pathway. This pathway has been the subject of intense preclinical and clinical investigation over the past 2 decades. And as you can see by the green font in some of the highlighted drugs listed, there has been some success in terms of FDA approvals in targeting this pathway in human breast cancer, ranging from here all the way at the cell surface by targeting receptor kinases such as the HER2 receptor tyrosine kinase that can be inhibited by small molecule tyrosine kinase inhibitors or humanized monoclonal antibodies, blocking mTOR, which lies along this PI3 kinase AKT pathway. Everolimus is also FDA approved in combination with anti-estrogens and has efficacy and has been approved by the FDA. More recently, alpelisib, an alpha-specific PI3 kinase inhibitor, has been shown to have activity in mutant PI3 kinase molecules. And finally, downstream of all the signal transduction machinery resides the cyclin CDK complexes that execute progression through the cell cycle checkpoint. And this, of course, is the target for the CDK4 and CDK6 inhibitors as shown. So intense areas of investigation resulting in therapeutic efficacy, resulting in new treatment options for our patients with breast cancer. So a lot of effort, but significant gains in terms of better control of the breast cancer problem for our patients. Now, starting at the receptor level, we and others have shown in the past that combinations of anti-HER2 with anti-estrogen receptor result in a marked attenuation of estrogen-dependent gene expression. In this case, a reporter construct driven by an estrogen response element, which is stimulated by both estradiol as well as tamoxifen in these HER2-expressing cells, whereas fulvestrant, a selective estrogen receptor degrading agent, markedly attenuates ER-dependent gene expression by degrading the estrogen receptor. And interestingly enough, anti-HER2 antibodies also attenuate ER-dependent gene expression, and the combination is superior. This had important biological consequences, and as much as the combination of a HER2 antibody plus fulvestrant resulted in greater increase in G1 arrest, as indicated by nuclear translocation and expression of P27, a convenient marker for cell cycle arrest. So there was more cell growth inhibition with the combination compared to antibody alone or fulvestrant alone in these experiments. This has been confirmed with lapatinib as well, in combination with fulvestrant, showing a marked diminution in cell proliferation with a dual receptor blockade approach. And this led to pivotal clinical trials of letrozole placebo versus letrozole lapatinib in triple positive metastatic breast cancers, resulting in an improvement in the median PFS from 3 to 8 months that was statistically significant, and a hazard ratio of 0.71, resulting in an accelerated FDA approval back in January of 2010. There was also an increase in the response rate and the clinical benefit rate, both of which were statistically significant. So this is proof of concept that targeting this PI3 kinase AKT pathway at the receptor level results in therapeutic efficacy in triple-positive breast cancer in this example. These results have been confirmed subsequently by more recent studies looking at combinations of lapatinib plus trastuzumab along with an AI compared to either trastuzumab alone or lapatinib alone in combination with the AI. And so these 3 drug combinations appear to be superior to single HER2 agent alone controls, and also the combination of pertuzumab plus trastuzumab is superior to trastuzumab plus an AI in the PERTAIN trial. Moving downstream in the signal transduction pathway to the level of mTOR, everolimus is a potent mTOR inhibitor and has been studied in combination with the aromatase inhibitor exemestane. In the BOLERO-2 study, which randomized 724 postmenopausal patients who were ER positive and HER2 negative with recurrence or progression following an AI, were randomized 2-to-1 to receive the 2-drug combination of the AI plus the mTOR inhibitor or placebo plus the AI with stratification for prior hormone therapy and presence or absence of visceral metastasis. The primary endpoint was PFS by local assessment. The results of this trial were impressive, with an improvement in the Kaplan-Meier estimate for probability of being progression-free and alive from about 3 to almost 8 months, with high statistical confidence, resulting in new drug approval for this approach as well. This same principle has also been established by the PRECOG 0102 study, in this case in combination with fulvestrant instead of an AI, but in this randomized trial comparing fulvestrant everolimus versus fulvestrant alone, you can see a statistically significant and arguably clinically meaningful improvement in PFS in patients randomized to everolimus in this study. The median overall survival was about 25 months with a combination versus not reached with placebo. Most of the adverse events have to do with mucositis and stomatitis, which can be mitigated by steroid mouth rinse, but also fatigue, anemia, hypertriglyceridemia, and in rare cases, some pulmonary interstitial changes that sometimes require clinical intervention. Now, PI3 kinase itself is a major regulator of normal cell processes in normal cells, including cell growth, proliferation, metabolism, motility, survival, and programmed cell death. PI3 kinase catalyzes the phosphorylation of phosphatidylinositol biphosphate to phosphatidylinositol triphosphate, which then activates AKT oncogenic signaling. Following AKT activation, AKT is localized to the membrane through its plextrin homology domain, whereupon it is phosphorylated by PDK1 and mTORC1, resulting in a fully active AKT1 enzyme that then goes on to direct cell growth, cell survival, proliferation, and metabolism signals. So this is a very important physiologic pathway as well as pathophysiologic process when these genes are altered by mutation, gene amplification, overexpression, gene deletion, etc. PTEN is a negative regulator of the pathway, so loss of PTEN has been shown to result in activation of the pathway as well. Many studies have shown now that in solid tumors, PI3 kinase pathway is the most frequently altered pathway in human cancer. Now, there are numerous PI3 kinase enhancing mechanisms in breast cancer, including mutation of PIK3CA gene, amplification of the gene, PI3R1 mutation or low expression. There are other PI3 kinase enhancing mechanisms. I've already shown you the example of HER2 amplification at the receptor level that can drive signaling through the pathway. Loss of PTEN can result in activation of the pathway, as can mutation of AKT itself. These PI3 kinase somatic mutations have transforming capability. These are typically gain-of-function mutations. They're oncogenic, causing tumor growth increases in vitro and in vivo in xenograft models, and they are more common in hormone receptor positive breast cancer than in basal-like tumors. PI3 kinase gene amplification is less common, with a frequency of just about 10% in breast cancer. This has also been shown, however, to increase PI3 kinase activity. So mutation of the PIK3CA gene is most frequently reported molecular alteration pathway in breast cancer. Now, these are a representation of the PI3 kinase family of genes and protein products. PI3 kinases are heterodimeric lipid kinases composed of a regulatory subunit and a catalytic subunit. They're encoded by different genes. PI3 kinase is grouped into three classes based on structure and substrate specificity. This slide focuses only on class 1. PI3 kinase enzymes are the most important in cancer. They're composed of the P110 catalytic subunit along with the PI85 regulatory subunit. Proof of concept has been established by targeting this pathway previously in 2014 when the FDA approved the drug idelalisib, which is a PI3 kinase delta inhibitor, and that is now approved for treatment of relapsed or refractory chronic lymphocytic leukemia in combination with rituximab, and also is approved for low-grade lymphomas similarly. So with that proof of concept in mind, one wonders, could targeting PI3 kinase alpha in breast cancer, which is arguably the most important active subunit in signaling for human breast cancer, could that result in similar efficacy gains as the PI3 kinase delta experience in hematologic malignancy? Overall, PI3 kinase mutations are the second most common mutation observed in all breast cancer patients, second only to P53 mutation. These mutations occur in about 40% of breast cancers and is higher in luminal tumors, whereas P53 mutations are most frequent in basal-like and also in HER2 positive cases. This is the spectrum of mutations along the PI3 kinase protein product. You can see there are point mutations in the P85 binding domain as well as the RAS binding domain. C2 is a phospholipid binding domain. The helical domain is responsible for binding to RAS GTP and is vulnerable to mutational activation as shown. And finally, the kinase domain itself can be the focus of activating point mutations, resulting in aberrant activity of P110 alpha catalytic subunit. This is the pivotal registration trial of the alpha-specific PI3 kinase inhibitor alpelisib in combination with fulvestrant versus fulvestrant plus placebo in hormone receptor-positive HER2 negative AI-resistant metastatic breast cancer. 560 patients were enrolled. There were two deliberate cohorts, one involving a PIK3CA mutant cohort of 340 patients and a non-mutant cohort of about 220 patients. Each of these cohorts underwent randomization in a one-to-one fashion based on stratification factors for presence or absence of visceral metastasis and prior treatment with CDK4 inhibition. And as I mentioned, they were randomized to alpelisib versus placebo in each cohort. These are the waterfall plots indicating change in baseline measurement of measurable lesions. And as you can see, the alpelisib randomized subjects enjoyed a more favorable objective tumor response as compared to placebo in these plots, with a much higher fraction having a decrease in tumor size as compared to baseline, and a smaller fraction with any evidence of disease progression also compared to the placebo plus fulvestrant arm. The primary endpoint of the SOLAR-1 trial was locally assessed progression-free survival in the PIK3CA mutant cohort. These are the primary endpoint efficacy data as shown with Kaplan-Meier analysis of the PFS probability. You can see that there was a significant shift at the median from about 5.7 months to 11 months, favoring the alpelisib randomized subjects. This result was highly statistically significant with a hazard ratio of 0.65. The mortality events are still few. Consequently, the overall survival data set is not yet fully mature. This trial included first-line and second-line treatment with alpelisib fulvestrant versus placebo fulvestrant, and in either line of therapy, there appeared to be a benefit for the combination with alpelisib compared to the control arm. Moreover, in patients who were defined as being endocrine-resistant patients, there was also a fairly impressive shift at the median from about 5 months to 9 months, favoring the alpelisib randomized patients with a hazard ratio of about 0.7. So in both of these clinical settings, it appears that there is retained activity of alpelisib irrespective of line of therapy between first and second line, including an endocrine-resistant population. This is the subset of patients who had prior CDK4/6 inhibition. And you can see that though this is a very small number of patients, the hazard ratio estimate is favorable at about 0.5. And you can see here, based on Kaplan-Meier estimates, that there appears to be some residual benefit even in patients with prior CDK4/6 inhibition. Without prior CDK4/6 inhibitor therapy, these results are reminiscent of the intent to treat population, since this is the majority of the patients indeed. Again, a hazard ratio of 0.67 in the CDK4/6 naive population indeed. In this study, it was possible to measure PI3 kinase mutations in tumors using plasma circulating tumor DNA. Consequently, a subset analysis was performed in patients who had PI3 kinase gene mutations in the circulating tumor DNA specimens. And this result was compared to those patients who had mutations detected by DNA sequence analysis in their tumor tissues. And you can see here the patients that had mutations determined purely by circulating tumor DNA, not requiring a tumor biopsy, clearly shows an efficacy signal in favor of alpelisib. So patients with or without mutations in either the tissue or in the plasma had similar point estimates on PFS compared to control, and similar hazard ratios between 0.55 and 0.65. So it's possible to glean mutational analysis information from either the primary tumor tissue or metastatic tumor tissue, whatever the case may be, as well as from contemporaneous plasma samples done at the time of study entry. This experience is reminiscent of a prior study of a different PI3 kinase inhibitor called buparlisib, which did not make it through drug registration due to toxicity issues, namely off-target effects, since this is not an alpha-specific inhibitor per se. But in this trial, there was a concordance overall between the PIK3CA mutational status in the tumor tissue compared to the ctDNA. However, the concordance was only 77%. Indeed, in 307 patients with PI3 kinase wild type in the tumor tissue, 79% had non-mutant ctDNA, but 21% had PIK3CA mutations in the ctDNA, potentially indicating tumor evolution between the time of initial diagnosis and the time of treatment on this protocol. So if you have a primary tumor specimen that appears to be PI3 kinase wild type, it would be important to check their PI3 kinase gene mutation status in the circulation using the ctDNA assay, just to make sure you haven't missed evolution during the progression of that patient's tumor from the primary event to metastatic sites. Moreover, there have been anecdotes of cases where the ctDNA assay proved to be perhaps false negative, and yet tumor biopsies of metastasis yield mutant PI3 kinase gene sequence. So it may be necessary to be completely thorough to test both when clinically available. This is the overall survival analysis at the time of the first planned interim. As you can see, the data are immature, as only 52% of the planned number of events for the final OS analysis have yet occurred. Nonetheless, there is an interesting visual trend favoring the alpelisib randomized subjects with a hazard ratio of 0.73 and a non-significant p-value due to the low number of events. Perhaps more time and more events will be necessary to determine whether or not the OS endpoint is achieved with further data maturity. Now, this agent has unique toxicities that clinicians must be mindful of. In particular, alpelisib, by virtue of the class that it targets, PI3 kinase, is capable of resulting in hyperglycemia. In fact, alpelisib was discontinued for hyperglycemia in 18 patients, or about 6.3% in this trial. So it's critical to serially monitor the glucose levels in alpelisib-treated patients and intervene if necessary with dose modification and or co-medication with oral hypoglycemic agents as clinically indicated if hyperglycemia develops. Also be mindful of the fact that SOLAR 1 had exclusion criteria for type 1 diabetics or uncontrolled type 2 diabetics, so we don't have safety information in those two patient populations as yet. Alpelisib can also cause lower GI toxicity as shown as compared to placebo, and if this rises to the level of grade 3, then dose modification and or intervention with anti-diarrheal agents may be indicated. Nausea and vomiting are also a feature of alpelisib treatment, which can be mitigated with co-medication with anti-emetic agents. And once again, if it's severe enough, dose modification may be clinically indicated as well. Rash is another very important, unique feature of the spectrum of adverse events from alpelisib. Sometimes these rashes can be severe, including cases of Stevens-Johnson syndrome. Erythema multiforme has also been reported. You should not initiate treatment with alpelisib in patients if they have a history of Stevens-Johnson syndrome, erythema multiforme, or a prior history of toxic epidermal necrolysis. If you see severe cutaneous reactions, alpelisib dosing should be interrupted until the etiology has been determined and consultation with a dermatologist and therapeutic intervention has been achieved. And it's recommended that for Stevens-Johnson's or erythema multiforme or toxic epidermal necrolysis, that alpelisib should be discontinued permanently. For milder rashes, intervention with topical agents and or antihistamines may be effective, as can dose modification help to mitigate against this particular toxicity. Anorexia and weight loss are also features of this drug, as is an increased risk of stomatitis and an increased risk of fatigue, as well as weakness. So all these must be followed closely, and clinicians must be mindful of these potential adverse events and intervene accordingly, including co-medication and or dose modification if severe enough. So the treatment sequence, in light of this new data set for postmenopausal patients with metastatic breast cancer in this example, would include CDK inhibition along with an aromatase inhibitor as a first-line treatment choice, followed by fulvestrant-based second-line endocrine therapy. And for patients with known PI3 kinase gene mutations, alpelisib is now a recommended option for that subset of patients, whereas for patients with wild-type PI3 kinase gene sequence, everolimus could be considered according to the PRECOG 0102 trial data that I showed you previously, or even single-agent fulvestrant in selected patients could be clinically indicated as well. In the third line, if patients are still everolimus naive, then everolimus plus aromatase inhibition could be indicated. If patients are tamoxifen naive, tamoxifen is still active as an endocrine manipulation in metastatic ER-positive breast cancer, as is high-dose estrogen as well. When patients become endocrine refractory and no longer have response to these endocrine manipulations, then chemotherapy as sequential single-agent chemotherapeutic agent use is clinically indicated thereafter. In conclusion, the therapeutic potential of PI3 kinase inhibitors in combination with endocrine agents in patients with metastatic breast cancer shows that recurrence and resistance after endocrine therapy for breast cancer still represents a substantial unmet need. PI3 kinase pathway activation is implicated in cancer progression and endocrine resistance. Mutation of PI3 kinase gene, an oncogene that codes for the PI3 kinase alpha subunit, is the most frequently reported molecular alteration of the PI3 kinase pathway in breast cancer. Approximately 40% of patients with hormone receptor-positive breast cancer have PIK3CA gene mutations. PIK3CA mutations appear to be predictive factors for P110 alpha catalytic isoform-specific inhibitors, such as alpelisib, which is now the first PI3 kinase inhibitor to result in meaningful improvement in PFS in a predefined biomarker cohort, i.e. PIK3CA gene mutant cases, and is better tolerated than prior PI3 kinase inhibitors that were not alpha-specific, including some inhibitors with pan-PI3 kinase isoform activity, and some that were delta-sparing and more alpha-selective. Benefit from alpelisib in PI3 kinase mutation cohorts appears to be similar, whether PI3 kinase is assessed from formalin-fixed paraffin-embedded tumor tissues or by circulating tumor DNA. For completeness, clinicians may want to consider measuring the PIK3CA gene sequence in both. The most common alpelisib adverse reactions of all grades with an incidence of greater than or equal to 20% include hyperglycemia, which may require intervention with oral hypoglycemic agents, for instance, creatinine elevation, diarrhea, rash, lymphopenia, transaminase elevation, upper GI toxicity, fatigue, anemia, lipase elevation, anorexia, stomatitis, weight loss, hypocalcemia, increase in PTT measurements, as well as alopecia. It's been my pleasure to discuss the topic of PI3 kinase inhibition in ER-positive metastatic breast cancer with you today, and thank you very much for your attention.